So I would request my close friend, Dr. Urooj, to please come on the stage and deliver the topic. Dr. Urooj.
Assalamu alaikum, everyone. I'm Dr. Urooj, and the topic today I'm going to do is sweating and flushing. So, sweating and flushing, should we start with it? Okay. Okay. So, okay, thank you. Sweating and flushing, two very common symptoms which we come across, especially in an endocrine clinic. But the problem is that there's not much written about it in endotexts. And not only that, but it's not only the presentation we endocrinologists see, it's the presentation with patients go to the dermatologists and gynecologists, and because of the varied causes. So I would like to, before going on to the topic, I'll just give you a spice of some clinical cases. So case number one is a 49-year-old lady presented to clinic, complains of episodic flushing with sweating for a few months. She's also complaining of amenorrhea for a couple of months. Her pressures and pulse are normal. Systemic inquiry was normal and had a normal physical examination. So very common at this age group, females coming to usually the gynecologists, and we know what's going on over here. Case two, a 34-year-old female was referred from her GP to our outpatient endocrine department with a few months history of flushing and sweating. Her symptoms had appeared within months of receiving a contraceptive implant, which had also resulted in amenorrhea, and she was very happy about the amenorrhea. Systemic inquiry was unremarkable. She was a non-smoker, drank no alcohol, denied using any prescribed or non-prescribed drugs. So now what's happening? It's something central happening over here. Case three, a 42-year-old man was referred for evaluation of a flushing disorder. His symptoms began about 7 years previously. At the time, he would flush only if he had an alcoholic drink and after large meals or exercise. For last 4 years, he started flushing without obvious triggers, and his symptoms worsened. By the time of presentation, he had 3 to 4 facial flushing episodes each day lasting 15 to 20 minutes, primarily involving his face and neck. With these episodes, he did not have any shortness of breath, diarrhea. He did not have hypertension. Over the past 4 years, he had developed a persistent red rash over his back, chest, upper arms, which was reported unremarkable on skin biopsy, performed 2 years previously. Over the past couple of years, he had also developed a sense of temperature dysregulation. He was not taking any regular medications, and there was no clinical significant family or social history. So a Pandora box opens, and now there is a list of things coming up in our mind. I will leave you all with this, and we'll go to the topic now. So definition, hot flushes and generalized sweating are relatively common presenting complaints, as I said. Flushing can be defined as sensation of warmth, erythema, which is commonly of face, and maybe other parts of the body. And it is episodic. Epidemiologically, as I said, there's paucity of robust epidemiological studies. Because one, it cannot be really explained in layman terms. People cannot really explain it, that what exactly is happening to them, the flushing and the sweating. Sweating they might, but the flushing they cannot really explain. Then because of the routes of presentation to the clinic, they might be presenting to a dermatology, they might be going to gynecologists, so there is a paucity of data. And then there's a large variety of conditions. Endocrine, non-endocrine, menopausal, non-menopausal. There's a large list of drugs, allergies. So that's why these robust epidemiological studies have not been done on it. So what we know, however, is 80% postmenopausal females, they have this presentation, 65% of men treated medically or surgically for prostatic CA. Common in men undergoing androgen suppression therapy. And then a variety of other causes which need to be evaluated in both the genders, including the malignancies and infections. We're not going to touch the malignancies and infections here. It's a very big topic. So we'll just stay on our own endocrine part. So what are the possible causes of sweating and flushing? And what can be the diagnostic clues? And what should be the suggested screening tests? So first of all, we'll come to the hypogonadism. Hypogonadism. And of that, menopausal. So main thing is the menopausal. And females of particular climacteric age and presenting with oligomenorrhea, we think they are having menopausal. Pre-menopausal, perimenopausal time period is going on. So that's what happens. While in case of men, it is actually the erectile dysfunction and loss of libido. Again, not frequently. You need to ask these questions because men tend to not disclose these things or they feel embarrassed while discussing about these things. So these are the things which have to be asked in the history. Well, when you ask about, you need to ask about headaches and visual disturbances because there can be a adenoma causing the symptoms over here. So physical examination in these will be youthful appearance and paucity of body hair, especially in males, and sparse sexual hair. And the investigations will be FSH, LH, estradiol, and 9 AM testosterone, and other pituitary function. What else we need to ask them? We ask them about excessive exercise, disordered eating, persistent focus on losing weight, chronic illnesses. So underweight and low BMIs, people having anorexia nervosa or bulimia, these are the people who can have the present because of the decline in the hormones, the estrogen and the testosterone. There has been a lot of theories that why does it happen exactly, and now it has been stated that it's all because of the levels of the estrogen and testosterone, and it's not the levels actually, it's how the withdrawal takes place. So if the withdrawal, if it is an abrupt withdrawal, so it will produce more pronounced symptoms. And in men, that is the reason, and when we give the therapy for the prostatic CA, they start having these symptoms. They don't, men also go through an andropause, but they do not have the symptoms just like the menopause occurs, the symptoms like females have in menopause. So because it's very insidious, the females, they have a little more triggered, they have more response to the hormones, and that's why they go through the symptoms. Then as the era of fast foods and the metabolic syndrome and the diabetes, so these people also, so we have to look for when patient coming to you with flushing and sweating and symptoms, you need to ask them about, you have to consider the metabolic syndrome, the dumping syndrome, and diabetes and hypoglycemia. So metabolic syndrome, we know difficulties in losing weight, and unhealthy eating habits, lack of exercise, family history of metabolic disorders. These need to be asked. When we will examine the patient, there will be elevated BMI and blood pressure, increased waist to hip circumference ratio, acanthosis nigricans around the nape or under the armpits. The tests which you will perform are HbA1c, sex-binding globulins, fasting lipid profile, FSH, LH, estradiol, and testosterone. Dumping syndrome. What's dumping syndrome? So a patient who has a bariatric surgery done or any surgery of the foregut. So what happens? The gut is short, food moves fast, and then insulin levels peaks, and then the patient starts having hypoglycemia. So the severe sweating post-meal occurs. So what should be done in them? We do a modified OGTT with measurement of serum insulin and glucose half hour up to 4 hour post 75 gram of ingested glucose. Diabetes, we have been talking about diabetes all day, yesterday, today, and diabetes, non-diabetic patients, so non-diabetic patients on oral or injectable hypoglycemia, they can present with this, or long history of diabetes with impaired awareness of hypoglycemia, and known peripheral neuropathies, and gastroparesis. So these patients can also present with sweating and flushing. So hyperthyroidism, we should never forget, if a patient is coming with sweating, we should never forget hyperthyroidism. And we have to ask about the weight loss, palpitation, hand tremors, hair loss, oligo and amenorrhea, family history, they have to be asked. Examination, the typical pulmonary edema, sweaty palms, tachycardia, goiter, thyroid eye diseases, signs like exophthalmos, ophthalmoplegia. And the tests would be TSH, thyroid function tests, TSH, that is TSH, free T4, free T3, autoantibodies, TPO and TRAB, ESR and thyroglobulin to differentiate the different causes of the hyperthyroidism in these patients, or thyrotoxicosis. Coming to the difficult part, the carcinoid, the medullary thyroid, CA, and pheochromocytoma. These are the things which an endocrinologist should have in his mind. He should think of these when the patient is coming to a female coming with symptoms. They should not get stuck with the menopause, that is, she's a 50, 55 years old. So, no, these are the things you have to think of. So, carcinoid syndrome, what will happen? You will ask about the episodic flushing with wheezing, abdominal pain, and diarrhea. Again, depends on the location, the metastasis, is there liver metastasis or not. No liver metastasis, chances are not, patient might not be having these symptoms. And then you have to examine for lymphadenopathy, you have to look for that. Investigation, chromogranin A and 5-hydroxyindole acetic acid after dietary exclusion, you have to get done. Medullary thyroid CA is recent neck mass, someone who has presented with recent neck mass, or hoarse voice, flushing with diarrhea, and then possible history of men too, if there is. Then you have to think of that. Neck mass and cervical lymphadenopathy on examination, and you will do a serum calcitonin levels. Pheochromocytoma. So these patients will have episodic sweating with palpitation and headaches. They can also have flushing. So if patient is coming with sweating, flushing, you cannot say that it is not pheo. You have to think of it. Possibly family history of men too, VHL or NFL. So these are the histories in history you have to ask. So examination, he can be hypertensive, normotensive, tachycardic, sweaty palms, but all signs may be absent, giving the episodic nature. So if he's not coming in episode, you might not get these signs in them. Tests, fractionated plasma metanephrine or 24-hour urine collection for metaadrenals. So what are the non-endocrine causes? So there's a whole list of non-endocrine causes, just the physiological emotional. So the blushing, which occurs, again, it's specific for a younger age group, the blushing, and some people have no, and this is not controllable. So that might be the reason. Alcohol-induced, food-related. I wanted to show this in food-related. There's a Chinese restaurant syndrome. We all are very fond of Chinese food. And some of the people have allergy to the MSG, which is in the Chinese food, usually in their soups. And it's a flavor enhancer. And patients, they might have dizziness, sweating, flushing, rapid heartbeat, and ringing in ears after taking that soup. So MSG is not only in Chinese food, it is an additive in many of the drinks and many of artificial the products, the canned products we get. But it's very commonly seen in the people after taking Chinese food. So food-related mastocytosis, because of the accumulation of the mast cells and release of the histamine. So that can lead to this severe sweating and flushing in the patients. This is not an exhaustive list. It's just a snap of it. So there are many drugs which can cause these symptoms. So all vasodilators, all calcium channel blockers, nicotinic acid, morphine and opiates, amyl nitrates and butyl nitrate, cholinergic drugs, high-dose dopamine agonists, thyrotropin releasing hormones, SERMs, anti-androgens, anti-estrogens. So the drugs we give to the patients. High-dose steroids, cyclosporine, rifampicin, sildenafil. So, and this is not an exhaustive list. So it's just a snap. Okay, the European Society tried to classify this flushing, symptom of flushing, and they classified as wet flushing and dry flushing. Wet flushing when there was sweating with it, and dry flushing when there was no sweating with it. It was a neural mechanism, so the adrenergic response and to the because of the adrenergic response along with there was vasodilation and causing the sweating also as well. Dry flushing, in which there is no sweating along. The patient has just flushing but not sweating. So it was the pathophysiology which was proposed was that it was because of the vasodilators. So the levels, the bradykinin, the serotonin, the prostaglandin, calcitonin, histamines. We are more interested in the calcitonin and the serotonin. These are the ones which have been shown. They tried to classify it in this manner. And they have proposed an algorithm for the evaluation of flushing. They say you ask whether sweating is there or not, and if the sweating is there, then it is clear hypogonadism. So if the hormones, the sexual hormones as are going down, they are activating your sympathetic system, and that's why if the patient is complaining of hypogonadism, has symptoms of hypogonadism, the most probable cause is that there is hypogonadism. But if it is not there, the symptoms, signs of hypogonadism is not there, then you need to exclude pheochromocytoma. So if neurological symptoms, however, if there are neurological symptoms along with it, then you need to look for the neurological causes. You have to refer the patient to the neurologist. Dry flushing is related, first you ask about the medications, then if yes, then you stop those medications and you reevaluate. If no, then you need to get these tests done. So 5-hydroxyinzole acetic acid and chromogranin for NET, catecholamines and metnephrines for pheo, tryptase for mastocytosis, VIP for VIPomas, calcitonin for MTC, and then if all are negative, then you can refer them for to evaluate for the allergies, different allergies. And they also mention if these are not that significant and the patient is having these symptoms, you can get the scans as well, the octreotide scans as well. There might be a small mass which is not giving that much amount of the hormone to be picked up, or it is not giving that much amount of hormone to have high levels of the hormones, but is causing the symptoms. So you need to get this scan, the gallium scan and the octreotide scan. This is another way of evaluating these patients. So if a patient has flushing, you go for history and physical examination and look for the causes. ठीक है, hypogonadism है कि नहीं thyroid के लिए, and if these symptoms are you can rule out some common serious causes like 24-hour urine for 500 for the carcinoid, for pheo, for the mastocytosis. You can get tests done for that. And then rule out less common causes by doing urinalysis, VIP levels. If normal, then there are other more rare causes which need to be evaluated, but they won't be endocrine causes. So if you have confirmed the diagnosis, then you treat the diagnosis. Over here, if the patient is also complaining of hematuria, then there is renal cell carcinoma as well. So you need to evaluate for the renal cell carcinoma. If VIP levels are elevated, then pancreatic cell carcinoma, thyroid nodules, so medullary thyroid CA, and IgE or skin prick test for anaphylaxis. So it can just be an allergic reaction. So for the management, if just we're talking about the flushing and sweating, so the main thing you have to give them antihistamines and somatostatin analogs. So studies have shown that these two drugs are the drugs to control these symptoms. And then you have to treat the underlying cause. So underlying cause, menopause, hormone replacement therapy, males, testosterone replacement, female, estrogen replacement. We have a lot of different type of preparations available, and any of these which are suited to, and these are individualized treatments. You have to give individualized treatments. One thing, if one of the option is not working, you can shift to the another option. But if you are exhausted, if you have exhausted all the options and the levels of estrogen are now normal in the body, and the still patient is complaining of these symptoms, look for the other causes. Look for the rare causes. Look for the other non-menopausal or the other endocrine causes in these patients. So what are the endocrine causes as we have been going through them? So first one is carcinoid. So carcinoid syndrome is there. So what you give is we start with long-acting somatostatin analog. Every 28 days, you give that. If it is refractory, then and has a liver dominant, then it depends on whether the patient. So with 3 more slides. So liver dominant disease with possible, if there is liver dominant disease, then you have to go toward the liver directed therapies like resections or chemoablation. Otherwise, you will go toward the dose escalation, increase the dose of the somatostatins, increase the injection frequency or switch it. Frequent diarrhea, then you can give the antidiarrheals to these patients. And then interferon alpha and the PRRT therapy can also be done. FEO, we know this is a treatment for FEO. We know these patients, they have to go to the surgery. There is a particular protocol which has to be followed. Cannot go into detail of this because of the time constraints, but we know all patients of FEO, their pressures have to be controlled pre-operatively, peri-operatively, post-operatively, we all have to, and there's a protocol which needs to be followed. Medullary thyroid CA, whenever you think of, you find a nodule, these patients presenting, you're looking for workup, you find a nodule, you do an FNA, you find out it's medullary thyroid CA, go for the red skin. We cannot do red screens here, so what we do, we go for the FEO and hyperparathyroid. We have to rule out the MEN syndrome in these patients. And then, if FEO is present, first surgery of FEO, then of the thyroid and the other surgeries. So that has to be done. If it is idiopathic, you did everything, exhaustive surgery, investigation, and you found nothing, then it is what to do. You need to reassure the patient. You evaluate every 6 to 12 months and you look for the progression of the symptoms. If there is no progression of this, there is no need of repeating these tests. Get a psychological evaluation of these patients done. Rule out any psychological cause. And the treatment is antihistamine, and steroids, they also help. But the main treatment is antihistamines in these patients. So coming back to the cases, I'm wrapping it up. Coming back to the cases, obviously this female has perimenopause, menopause and menopausal, so you can see. And if you do her FSH and LH, they will be skyrocketingly high and with a low estrogen. In this case, what do you think is happening? So she's this is a 34-year girl, a female who came for contraception, got a implant, and then started having flushing, and then there is amenorrhea. So what's happening over here? So investigations showed a low LH, a low FSH, and with low estradiol. So what's happening? Whole the axis is gone. So what happened? The drug from the outside has shut her system. That's what's happening. And you need other tests were also done which were normal. So this is HPG, the hypogonadal pituitary axis has been affected, gonadal pituitary axis. Here, the interesting case. So what do you think is happening here? A man with symptoms for 7 years, becoming persistent, and episodes with no shortness of breath or diarrhea, no hypertension, and then this persistent rash, worked up, and the biopsy done, one skin biopsy, nothing there. So a complete blood count and routine chemistries were done, which were normal. Serum serotonin and serum tryptase were normal. 24 urine for 5-hydroxyindole acetic acid was normal. So fractionated metanephrine catecholamine normal. Skin biopsy showed telangiectasias. This time when it was done, 2 years back it was normal. Serum calcitonin 552. So ultrasound of this led to ultrasound of the thyroid, 1.8 cm suspicious nodule in the mid-right thyroid lobe. Fine needle aspiration done showed a medullary thyroid CA. Near total thyroidectomy worked up for men, negative for that. Near total thyroidectomy was done. Histopathology showed MTC of 1.8 by 1.4 by 1.1 cm mass, And there was incidentally 0.7 centimeters papillary thyroid CA as well in the mid portion of the right lobe of the thyroid. After surgery, there's complete resolution of his symptoms of flushing and rash. 6 months follow-up visit, undetectable serum calcitonin concentration, normal concentration of CEA, neck ultrasound showed no evidence of adenopathy. So, a patient coming with just with flushing and sweating ended up having a surgery for medullary thyroid CA. So very common presentation, coming to varied causes, common being menopause, hypogonads, and drug, but we have to look for the other causes. A detailed workup need to be done. Treatment is dependent on the underlying cause. Find out the cause and then treat. Symptomatically, you can give antihistamines. It can be idiopathic in the end with no cause, and you will need to just follow the patient without, just follow and ensure the patient. In the end, I will just say life is to learn new skills, and let's try to learn new skills every year, make our children learn new skills. Thank you.